Hi everyone, my name is Meredith McCrory and today I will be presenting my DNP project, a multimodal strategy to activate pronation for acute respiratory distress syndrome patients. This project was created in conjunction with Dr. Douglas Stevens, faculty chair, and Ms. Beverly Sims, service chief. When looking at the background, ARDS is an acute pulmonary process that compromises the health of patients in the intensive care unit. This can progress to irreversible fibrosis, causing the lungs to become non-effective and non-compliant, which affects ventilation. An ARDS diagnosis accounts for 30 to 40% mortality rate, and annually nearly 200,000 patients in the United States are diagnosed with ARDS. When looking at worldwide, the syndrome is responsible for 10% of all ICU admissions, with 23% of patients requiring mechanical ventilation. However, manual pronation of ARDS patients has shown an increase in alveolar function, which leads to improvement in oxygenation and rate of survival. When performing a needs assessment, it was found that ARDS patients accounts for 10.4% of ICU admissions in the United States. This accounts for nearly 190,000 patients having a diagnosis annually. When looking at the southern region of the United States, 21,753 individuals died from ARDS, and that's nearly doubled from individuals in the Northeast and Midwest areas. The age adjustment mortality rate for the South is 3.4 per 100,000, and Alabama showing an increased age adjustment mortality rate of 4.7 per 100,000 patients, and that occurred between 2014 and 2018. In my facility from October 2020 to October 2021, there were 457 admissions for both the MICU and CCU, with 9.8% of those patients having a diagnosis of ARDS that could benefit from pronation. Many were transferred to other facilities during that time to receive pronation services, or they were treated strictly in the supine position. The purpose of this project is to implement a validated pronation protocol to offer an evidence-based intervention for ARDS, this in turn increasing pronation for ARDS patients. The learning objectives for this project focus on the expansion of the existing guideline to include all ARDS patients, increased ARDS recognition by the nursing staff, earlier utilization of pronation, and advocacy for pronation from the nursing staff. These four objectives align with existing literature which advocate for increased awareness of ARDS identification, appropriate therapeutic strategies, and stakeholder buy-in. The project aimed to increase the lack of pronation by adopting a protocol which highlights criteria and the process. The theoretical framework I chose for this project is Havelock's stages of plan change. It was utilized for this project since it clearly outlined the strategic steps for implementation of a process change. In preparation for project development, there was a need for a process change related to ARDS patients. To foster this change, collaboration with stakeholders was conducted to support the pronation protocol. The collaboration aided in fostering relationships with stakeholders and to support the integration of the pronation protocol. To achieve this goal, I had to acquire the most up-to-date literature and best practices for the protocol development. Once standard operating procedure was finalized, or the SOP, identifying the appropriate mechanism for educating the staff of MICU and CCU was needed. This dissemination was achieved through intentional staff engagement in the form of educational opportunities and simulation experience. Integrated intentional opportunities for staff feedback within real-time training to address any concerns they have regarding the SOP or education. Following implementation, collaboration occurred with the unit educator to develop sustainment of educational opportunities with new and existing staff. Since 1976, pronation has been increasingly used to treat patients with ARDS. Over the last 50 years, there have been numerous studies to include systematic reviews, meta-analysis, and clinical trials that explore how prone positioning impacts this patient population. One of the more dynamic studies, by Munchie, evaluated existing literature published from a 2010 systematic review and updated the findings with literature through 2016 to evaluate the impact of pronation on the 28-day mortality versus those patients treated with conventional mechanical ventilation in a supinated position. The authors of this study identified 8 randomized controlled trials across a 12-year span that indicated no mortality difference. However, the subgroup analysis showed decreased mortality when prone 12 hours or longer per day for studies with moderate to severe ARDS. The takeaway from this particular study is the greatest benefit for ARDS patients is longer pronation. In Elpern, a more recent study published in 2021, the researcher confirmed previous findings as they evaluated prone positioning with ARDS and COVID-19. These authors theorized that extending pronation periods beyond 12 hours may be needed to further support positive patient outcomes. They suggest extending pronation periods to 16 hours and returning the patients to supine for 4. In 2013, the PROSEVA trial standardized the criteria to evaluate patients for proning. The trial identified prone patients had a mortality rate of 16% compared to 32.8% of supine patients. Further literature confirmed the current evidence that supports prone positioning is beneficial for ARDS patients due to improved gas exchange, redistribution of pulmonary pressure when turned from supine to prone. There's also evidence that indicates supinated positioning for humans is unnatural since patients who are supinated experience additional strain on the lungs. Most individuals sleep prone or semi-prone, yet the ICU patients are treated in a supinated position. Pronation within the ICU setting is relatively safe and inexpensive. However, this technique requires teamwork among the staff to manage unforeseen complications, such as extubation. The addition of protocols and guides can also alleviate this risk. For the pronation process to become integrated into daily routine of the staff, a multimodal approach, including dissemination of various educational materials and tools, should be implemented. Various studies have demonstrated numerous tools, including protocols, guides, and/or bundles, should be used to implement best practice techniques specifically in an ICU setting. An educational tool utilized to prepare staff is simulation. The use of simulation has steadily grown and has numerous benefits, such as greater acquisition and retention of knowledge and collaboration among staff when compared to traditional educational approaches. This gives nursing staff the opportunity to identify errors in the pronation process that may result in unforeseen outcomes for the patient. This quality improvement project examined the catalyst use of a multimodal strategy to increase the overall usage of pronation as a non-invasive intervention for ARDS patients. In 2021, 457 patients were admitted to the medical center. For that year and before any intervention was implemented, 4.4% of patients met criteria for pronation, but it was not utilized. Following education of the nursing staff on the protocol, including the standard operating procedure, the checklist, and the proning kits, an Excel data collection spreadsheet was developed to track any admissions, diagnosis of ARDS, dates of intubations, pronation dates, and any complications related to proning. So for the project implementation, to begin with, a standard operating procedure had to be developed for the facility. There was a collaboration among different facilities of federal facilities throughout the United States and Our federal facility SOP was modeled from the Lexington VA, which is evidence-based and had been used in their facility previously. From the SOP, there was a pronation checklist that was modeled to give the staff criteria for pronation, any pre-pronation activities that they needed, the pronation kits, which included Mepilex, any type of electrodes that they needed when they prone the patient. They also had opportunities for simulation. I offered 8 simulation activities for both day shift and night shift on various dates to get 100% of the staff. Once that was completed, I started collecting the data within the 2 units to monitor all the patients that were being proned. So the outcome for this, the aim of this project was met as demonstrated by the increased number of patients proned. This study adds to the existing literature that supports the alignment of a multimodal educational offerings targeting healthcare providers and process improvement initiatives. Having a standardized process and protocol allows for increased usage with the nursing staff as they identify patients with or at risk for developing ARDS. They then in turn can advocate for pronation for this subset of patients. Having a standardized process and protocol should increase ease of usage by nurses when providing a targeted intervention. This process supports the theory of targeting specific barriers through educational initiatives to result in greater success regarding staff knowledge and staff implementation. ARDS remains a condition with high morbidity, mortality, and high cost to the individual. This project sought to provide standardization through a multimodal approach with education focusing on the SOP, evidence-based checklist, and simulation exercises for the nursing staff for both the MICU and CCU. Although the sample size was relatively small, we only had 5 patients that met criteria. There is evidence to support the use of standardized multimodal approach for pronation. Since the implementation sample size was small, continued study to conclude a definitive improvement in pronation interventions for patients meeting criteria is needed. Once evaluation of possible benefits of pronating ARDS is completed, dissemination of finding was shared to the service chief of the intensive care units and the associate director of patient care service within the facility. Collaboration with the unit educator occurred to develop an annual competency to ensure education regarding ARDS criteria and the process of pronation is maintained. It will also be included in the initial competency education for the new nursing staff hired for the units. The surgical intensive care will also be included to ensure all critical care nursing staff are competent in recognizing ARDS. I would like to dedicate the completion of my DNP project and program to my grandmother. She passed away January 15th, 2021 from complications related to COVID-19. I would like to thank the faculty and staff of JSU, specifically Dr. Stevens, for all his mentorship and guidance throughout this process. I'd like to thank Ms. Sims, my preceptor, and my family and friends. Here are my references. Please let me know if you have any questions.